diabetes.
Ladies and gentlemen, thank you very much. A very warm welcome to each and every one of you. Professor Mike Dodds, and these are my words, an eminent Indigenous leader, tells us deeply this, and it's a caveat for tonight, about tonight, and our commitment to country. He says eloquently this: when we talk about country, we mean something beyond the dictionary definition of the words that are said. We might begin by thinking it's talking about homeland, or a tribal or clan area, or maybe just a simple place on a map. For us, and for me, country is a word full of all values and places, resources, stories, and cultural obligations associated with those areas that are featured in that country. It describes the entirety of our ancestral domains. It is therefore within the context and framework of those words by Professor Mike Dodds that I, on your behalf and mine, I'd like to begin by acknowledging the traditional owners of the land in which we meet today. I would also like to pay my respect to elders past, present and emerging, and in particular within the context of this evening, the Darug land where the Aboriginal people are so disproportionately affected by diabetes. I'd like and I hope that you found the exhibitors a really interesting way to celebrate 10-year anniversary of what has taken place and continues to take place here. There's lots of work that has been done, and I thank each and every one of you for that. We have over 200 special guests here, but I would like to simply acknowledge the following, if I may. Loretta Demonto, Board Chair, Western Sydney Local Health District. Alison Taggart, Acting Chief Executive, Western Sydney Local Health District. Sophia Androkopoulos, CEO, Australian Diabetes Society, Melbourne. Natalie Wishker, CEO, National Association of Diabetics Centres for Melbourne. Jack Miller, President of the Workers Lifestyle Group. Natalie Smith, the General Manager, New South Wales ACT Diabetics Australia. Jane Travis Draffers, Co-founder of Box Divvy. Graham Buzz Bistrup, Chief Executive Officer, Uncle Jim's Thumbs Up Limited. Pauline Hedges, Citizens Assembly, Went West. Ed Dung, CEO, Health to Sync. Wah Cheng, Director of Diabetes Endocrinology Department, Western Hospital. And Ming Hing, Head of Diabetes Endocrinology Department, Blacktown and Mount Druitt Hospitals. And Sashi Peng, Professor of Urban Health, Environment, School of Health at the University of New South Wales. And in fact, to give you some understanding of the people in the room, there are something like 30 nurses, 15 general practitioners, 15 board chairs, directors or seniors, executives and CEOs, 7 dietitians, 5 mayors or MPs here tonight, and many distinguished academics, hospital direct doctors, allied health, pharmacists, pharmaceutical representatives, food industry people, council workers, non-government organisation people, consumers, local and cultural organisation people, media and students. To all of you, a very warm welcome. And I say that welcome in the sense of who we have represented, particularly in the last 10 years. I'm very blessed to know probably 30% of you in this room, and to be committed and welded to you tonight is a very tangible way of saying we are in this together. In life, and I'm very big on this in my own family, so I share with you the humanness. You either have regret or discomfort when you talk with people. My motto is to have discomfort. For far too long, it took a long time for me to understand that with regret, it sticks with you forever. So I don't mind a bit of discomfort in dialogue, even when it's painful. Tonight is a really significant night because I'm asking you, if I can say that on behalf of all the organisations that we represent, we need to step up. If not me, who? If not now, when? And I'm very big on that as I approach certain ages in my life. I'm very blessed, and I'll give you one little thing from here. I'm very blessed to have 13 grandchildren. Doesn't matter if you've got one or none. But for me, I want a future for them to live the best that they can. When you look at my right, your left, there are three very, very, very important messages over here. We either walk past it and pretend we don't see it, or we step up or step back. We have discomfort or regret. I don't want to go to my grave, and that's the earthy part of it, knowing that my grandchildren are overweight. I did nothing about it. I did nothing about exercise. And when we look at the public purse, I saw Steve Barley just a moment ago, $1.8 billion, $18,000 per capita, spent trying to unearth and find solutions for this insidious disease. And as Professor Glenn was saying, and we were just talking, that's just the direct costs. So tonight is very special for me to be. I've driven 100 kilometres to come here. That's a commitment to us. Not me, you, us. And at the end of this, Norman and I want to put a proposition to you. Step up, step back, get involved or don't get involved. Your very commitment tonight says you're involved. So, are you excited? Oh, terrific. I'm really glad I come to 100 kilometres. But I try to be very earthy about it. This guy in front of you has 2 stents in his heart, verging on 7 as a figure, for those who understand that. So it's close to me. Very close. Very close. And I train, I watch what I eat, I do everything I can for a person my age. And yet, time and the impact of tonight is against me. Can I just say that to you? And when you get this part of the equation of life, it has even more value, in my humble opinion, with regards to that. Well, I think I'm going to ask a person who I admire very greatly to come to the podium. We are so blessed to have you here tonight, Norman. You have been an ambassador. You have been a person who really has taken the fight up to the public about the role that you play, not only as a medical doctor in your own right, and Stephen and I were talking, and you had a practice here. So I'm blown away by that. I didn't know that. And now you'll be able to share with us through your panels to take us on another journey. Ladies and gentlemen, Dr. Norman Swan, please. Thank you.
Thank you very much. So thank you very much for having me. Yeah, I was, when I made the transition into broadcasting, I kept an insurance policy just in case it didn't work out. And my insurance policy was here in Blacktown. And at the weekends, I used to drive out to Kildare Road with Michael Fasher and the paediatric primary care practice there, so that I didn't lose touch with clinical medicine. And eventually, after about 5 years, realized that the children of Blacktown would be much safer if I didn't look after them any longer. But it was always a pleasure. It's there's a grittiness and Jim used the word earthiness, but there's a grittiness to the community around here. This community has grown beyond measure in those years since I drove out every weekend to Blacktown. It's bigger. It's actually, it has prospered in the true sense of the word. It's a great city, and one that we should all be proud of. And community, I think, is going to be a strong theme in today's discussions. When the pandemic broke, people were looking to government, to whoever, to solve the problem of the pandemic. And in Western Sydney and southwestern Sydney, they kind of lost the plot a little bit in terms of the authorities and control. And really, what became clear from the people who actually understood pandemics and had worked with pandemics such as Ebola and others is that governments don't solve pandemics, doctors don't solve pandemics, communities solve pandemics. And it was when in New South Wales you started getting some community-based activity going in western and southwestern Sydney, same in the Northwest Corridor in Melbourne, that you started to see results rather than people feeling alienated. We tend to think that particularly in these days where you think you can get an injection and solve all your problems with diabetes, one injection a week. The reality is these problems are based in communities, and we are where we live in many ways. And you're going to hear examples of people who work with communities to actually create these solutions. And it's probably the most potent solution of all. But let's hear, to begin with, from some of the people who were at the beginning. This is a celebration of 10 years of incredibly hard work, where I'm sure Glenn had people telling him, you can't do this, it's impossible, how are you going to do this? Western Sydney's so huge, so diverse, how on earth are you going to do this? You're off your nut, you're off your rocker. But there were 3 people who believed Glenn's vision and shared it and helped to promote it. And I'm going to invite them to the stage now. Steve Leader, who's Emeritus Professor of Public Health and Community Medicine at the University of Sydney, and made sure early on he moved from Camperdown to Westmead. He moved out to the western suburbs because he knew epidemiologically and socially that's where he should be. Professor Stephen Colliguri, who's Professor of Metabolic Health Medicine at the Bowden Initiative at the University of Sydney. I often say, when safety and quality in healthcare, we tend to focus on surgeons because surgeons kill people very quickly, the very days, and argue that why don't we talk about endocrinologists because they kill people slowly. But Stephen is not one of those endocrinologists, nor are the hard-working endocrinologists who get involved in the case consultation, which is core to the activity of Western Sydney Diabetes. And last and certainly not least, Walter Kmet, who's moved to the dark side. He's gone from primary care to high-technology medicine. But nonetheless, we will still welcome Walter as the CEO. Were you the founding CEO of Wentwest? You were, weren't you? No, not. Your board chair is telling me the truth of the matter, but certainly was involved. And you cannot do this without primary care. So Steve, just take me back to the beginning. What did it look like epidemiologically then? And in terms of formulating a way forward here, which wasn't really seen elsewhere. I think if you just turn that on, it'll all work.
Right at the beginning, it was pretty clear from what we could discern in the patterns of health and illness in Western Sydney, especially beyond Westmead Hospital into the Western Sydney community, that there was a lot of diabetes, and by that I mean a lot of manifest diabetes as an illness and a lot of complications. And the surgeons at Westmead Hospital were amazed at the number of amputations that had to be performed for people with diabetic blood vessel disease, and the ophthalmologists were commenting that they saw a lot of people with eye disease that could be traced to diabetes. And so right at the beginning there was a discomfort, both among the healthcare professional community.
And this is, just to wrap, and this is without even talking about stroke or coronary heart disease.
Yes, well, that as well, but it's pretty common in its own right without any help from diabetes. But if you go into the origins of the blood vessel disease that leads to limbs needing to be amputated, diabetes has got an unenviable but distinctive reputation. So just at sort of first glance, without the aid of any surveys or sophisticated statistics, we could see that there was a very big problem with diabetes.
And the causes? Because you tend to think, oh, it's obesity, it's bad diet. But, you know, in public health, you talk about upstream causes.
Yes, well, it was fairly apparent that a lot of the diabetes that we were seeing was of the type 2 variety, which can be the end product of a disordered metabolism relating to years, if not decades, of abusive eating, I'd call it that, and significant overweight and obesity. So the constellation of metabolic problems that we were seeing suggested that there's a lot to be done, and a lot of those things originate in the lifestyle and the family patterns and the personal patterns of behaviour. They're not things that you can write a prescription for or give an injection for, but they're things that relate to the individual's place in society. And I'm not saying, therefore, that it's all the problem of the individual, because so many of those social circumstances limit or promote good or bad health-related behaviour. And we need to be very sensitive to that and not say silly things to people who are not really in a position to move much. If you're getting up on the road at 7:30, part of your employment, and you don't get home until after it's dark, and then that individual doesn't want to hear about happy chats of going for a jog before the day starts. Or the woman who's having to care for 2 or 3 children on her own, flat chat. So the recognition of social factors and personal and family factors in the origins of diabetes is very important, because they do give us a clue about what theoretically could be done. But the practicalities of actually doing something require a lot of sensitivity and reach into the realm of politics and economics, which is real tiger territory. But it's partly where we have to go.
Stephen, as in Colaguri, in some senses, prior to this, not experiment, but this innovation, this system innovation, I mean, endocrinologists were really stuck within their rooms or in hospital outpatient clinics. To talk about the challenge of bringing the specialist expertise to primary care and to the community at large, and building on what Steve's just been talking about.
Yeah, obviously, the majority of us.
You might want to. It's old-fashioned, but it works.
Obviously, the majority of us don't know how to use a microphone, but that's another story. So the majority of endocrinologists basically do practice one-on-one. I mean, they see a patient, they try and do the best they possibly can for that patient. But I guess it was fortunate that that I was actually involved with the broader challenge of trying to do something at a more community and public health level, and that occurred through the development and contribution to national diabetes strategies, where it was clear that although it was very important for the individual that we saw to do the best we possibly could, there was more that needed to be done to actually stop those people coming into our rooms. And that was what, for me, motivated me when Glenn and Steve and others asked if I could sort of be involved in a small way here. It was an opportunity to take all that theory that we write about in national strategies and to actually try and implement it. Because although we've had a whole series of national strategies, at least 4 in the last 20 years and the most recent one in 2021, it's very difficult to actually implement what's required at a community level to actually prevent diabetes or to actually provide the models of care and levels of care that people require beyond what you can just do on a one-to-one basis and address all the issues that Steve Leder has actually just mentioned.
Now, the problem seems so vast. I mean, some surveys would suggest 30% of the population with pre-diabetes, 15% with frank diabetes when you actually go looking for it, in a very large, very diverse population. Probably a little bit more concentrated now than it was 10 years ago. But what did you see as the biggest challenge?
Well, it's difficult to say what the biggest challenge is because the whole thing was just a big challenge. And I think
but people, that wasn't news, but people were overwhelmed by that challenge rather
Sure.
than taking action.
Yeah, no, so I think that I think that one of the main things that, and to again just refer back to this program, is that it was first of all decided that sure, it could be addressed if you just took it a bit at a time and a piece of it at a time. And the fact that we're here 10 years later, the fact that it was obviously acknowledged at the beginning that it wasn't going to be done over a 3-year period, which is a normal political cycle. And I think that the program has actually addressed all the key issues that are involved with trying to reduce the burden. There's issue about, obviously, prevention, screening. There are a whole stack of people out there who obviously one will hear about more and more during the evening. And what this program has contributed in terms of identifying those, getting them to care. And then there's the actually improving the model of care, because even as a single practitioner, it's just overwhelming trying to do everything that's required even for an individual, let alone all those people who never get near the sort of service that they require because they don't know they've got diabetes, or that they don't have the access, or they can't afford to go, or they can't see dietitians, etc.
But the temptation then presumably would have been, well, let's do a population-based screening program, but they don't work in type 2 diabetes, do they?
Well, it's a case of, I don't know what you really mean by don't work, because I think to encourage people to think about diabetes, to actually go and get tested, does actually identify people who have a problem and therefore can start to address it. So sure, you know, I mean, we don't really recommend that the whole population be screened for diabetes. It's more the high-risk people, and of course there's a lot of high-risk people in this area. But it's the first step towards getting to the sort of care that one requires in order to do something about the problem. Walter,
General practice in Australia has been described like herding cats or kangaroos, and that was your role as CEO of Went West to corral. But there's always been a core group of highly committed general practitioners in this region, has there not?
That's absolutely right, and first and foremost, I guess being here today, meeting a whole lot of the people that made a contribution is a great honour. I mean, it's been 10 years as we're all here to celebrate. It's great to see all the faces that made so many contributions to us here 10 years later. And I haven't seen Michael Fasher, by the way. He might be around here somewhere. But it's people like that if we talk about the herding cats, there are people really willing to step up and take a system approach. And I think it was mentioned earlier by you, Norman, about governments. Well, governments won't solve problems, but partnerships will. So when we looked at the problem that we had, some of the problems that we've just discussed, it was never going to be done by a doctor, whether it be an endocrinologist or a general practitioner working in their own office. It wasn't going to be done by one part of the system working on its own. It was going to be done by different silos, as you would have them, different silos coming together, perhaps people breaking the rules around the wage parts of the health system should work, and forming partnerships across the various parts of the health system, the human system, and indeed our community, to solve the problem, because it wasn't ever going to be solved by a single general practitioner, never going to be solved by a single endocrinologist, or probably never be solved by a medical person, frankly. But at the end of the day, our role, our obligation, certainly if we talk about West, was to encourage those partnerships to take place, for people to think about working as a system, as Di O'Halloran so often and so forcefully pushed over many years, operate as one system, as if you are one system. And I think the challenge for us has been to do that. But I think the fact that willing people were in that system to step up, including some of those cats you talk about, including the specialty of endocrinology at Western Sydney Local Health District. There were specialties at Western Sydney Local Health District that didn't want to play in this kind of space.
You shocked me. You shocked me.
We had 3 specialties actually. The one that stepped up was endocrinology, I have to say, and the others had every opportunity to do exactly the same thing, and that's why we're here.
Now, people talk increasingly about the financial incentives, the financial models, reimbursement, and it just works against, at every turn, it works against integrated care, it works against continuity of care. If you're an endocrinologist in private practice, or indeed a general practitioner, you're not properly remunerated, if indeed you're remunerated at all, for these activities. How did you get it going, given people weren't going to make money out of it?
I think the first conversation I had tonight, someone said to me, "Gee, you've got a lot more grey hair." I'm not sure where that grey hair came from, or the lack of hair came from.
It's only from Macquarie Health, it's not from Went West.
Absolutely. But I would, dealing with all those specialists perhaps, but I think there has to be leadership within the system. I think one of the tenets around being able to do things differently is for people to think outside what they're dealing with on a day-to-day basis, and begin to provide leadership around some of the issues that perhaps so intuitively you shouldn't do. One of those in diabetes is team-based care. How do you have team-based care if everyone is incentivised individually? Well, I think we have to, as a system, and certainly Danny at the local health district, we as a primary healthcare network and others, put money into people to behave in different ways, to actually have incentives to do things differently. So we were willing effectively to put our money where our mouth was, for people to be incentivised to behave actually as intuitively you wouldn't otherwise.
I want to finish now with just looking forward. I mean, we do have a panel right at the end about looking forward, but I want to hear from you 3 about looking forward. The focus, as you've all said, this was not going to be achieved in 2 or 3 years, if not even going to be achieved in 10 years. And a lot of the focus has been on secondary prevention, just getting people detected, managed, reducing the complication rates. Primary prevention, which Jim's going to deal with in a moment, has been late to the party. Where do you see the high priorities for moving forward in terms of tangible action? Steve?
Well, I think first and foremost there needs to be the definition of a sort of overarching strategy whereby we do move forward. And I'm very impressed with what can be done for a huge number of people when small effective changes take place. I'm just looking up the hall now to the 2 kilogram challenge poster. Not going to give it a prize or anything like that, but it's a good example, I think, of identifying something that's within the range of doability that might have great impact across the majority of the at-risk population you've spoken about. Healthy food choices clearly is another field where education of the population is very helpful, so that they can make choices between competing products, if you will, on the basis of their health benefit. When we started all of this many years ago, there was a program called Healthy Hearts West, and we had, at an open day at Blacktown Hospital, a caravan with an open side panel and various varieties of food which were clearly unhealthy. Sausages and God knows what all lined up. And the number of people that came to that caravan asking to buy some of these products was just amazing. So there was clearly a huge gap in what we'd call nutrition literacy. It wouldn't be all that difficult to tackle little by little. And while we're waiting for the new dawn of primary prevention and community reformation and all the rest of it, we may be waiting a long time, but those are identifying those little things that can be done, pinned on the back of an educational initiative, deserve a lot of thought for the future.
Stephen?
So I think the program has obviously achieved a lot, and if it continues in the same vein, it's going to achieve a lot more. And in terms of the future, I think there are two things. One is to maintain strong leadership, and obviously the program has had a group and Glenn as a driving force, and I think that that's necessary, and I don't know how long Glenn intends staying in the role, but I hope it's a long time. But if not, to ensure that there is a very strong succession plan. And the other thing is, I think, to maintain the integrity of the program. What's happened around the world and in Australia is that the programs, especially ones that are successful, start to be diluted. And for very good reason. I mean, obviously diabetes shares many risk factors with other conditions like cardiovascular disease and dementia. But still, there are many things that are really specific to diabetes. And what's happened around the world is that the programs then say, oh, we'll then do cardiovascular disease, and then we'll do dementia, and then we'll do stroke, and suddenly the diabetes focus is lost. And I think it's really important to make sure that the focus is maintained, even if other things are sort of added, but as long as the diabetes part doesn't get diluted.
Walter?
So perhaps I might pick up Jim's mantra from a bit earlier and create a bit of discomfort. I think the thing about the future is really the thing that we started with, and that is to rebalance the system away from the acute side of health and really back to primary care in the community. And I think that is really the future success of this program, as we've done, as the program has done. You know, the big steps that the local health district took, and Glenn and others in the leadership team took, was to say, well, we're going to move some money away from this acute end and back into the community, create capacity and capability in the community, and try to attempt to solve problems in that way. And I think, to me, that's still the future. We have to rebalance the system away from what we see as the end point and to the beginning point of some of these things that have been are working well now, and I think can continue to work with that support.
There you are, a leader of a private hospital cutting his own throat commercially in front of this audience. Could you please thank our fantastic panel? Oh, hi.
So today we are privileged to gather here in Workers Blacktown Ballroom to address a pressing issue that affects our community, which is diabetes in Western Sydney.
Our charter, I'm really speaking from my heart, is to encourage others who need our support and help.
We know the cost of diabetes in Western Sydney is about $18,000 per person. And considering our catchment of about 1 million people, that puts the cost at a staggering $1.8 billion a year.
By preventing future cases of diabetes and by better managing people who have diabetes today, we can then prevent a large portion of this cost from happening.
It means an enormous amount to me as your minister that so many of you are invested in one of the biggest challenges our health system face, and arguably the biggest challenge for the community that all of you love and are serving. We know that diabetes is Australia's largest disease burden, even though 80% an incredible 80% of the condition is preventable. In this, I want to commend all of you for initiating what the previous speaker talked about, the Lose 2 Kilograms, Beat Diabetes Together campaign. It bears a powerful, but more importantly for me, achievable message that just a moderate amount of weight loss can substantially reduce the risk of diabetes. It makes people feel as though they can play a role in improving their health outcomes and improving their health trajectory, something I'm really, really passionate about. It focuses on an achievable amount that people can try and reduce that will have a big difference to the level of healthcare and to the level of health that they're going to be living with going forward.
One of the things that the Alliance has learnt over many years of partnership has been how challenging it is to understand and make healthy food choices.
Most people's knowledge of nutrition is not that great, but they're really keen to learn more.
It's important to set small, measurable goals, and it's all about revamping your diet, track progress, get moving.
The whole community needs to combine forces to ensure all of our Minion residents have access to healthy food and have the skills to prepare healthy food for themselves and their families.
We've identified that there is a tremendous need for a community-based diabetes prevention program. And we really need to address awareness of diabetes. We need to really educate people about diabetes, but also to provide them with doable actions.
Give it a shot. Try and download the Good Tucker app and start looking in your pantry, and you'll find out that there's quite a lot of products that you think are healthy, but are not actually that healthy.
This is the start of a journey in terms of losing 2 kilos. We've been on this journey for a long time, but this new campaign, it is the start. What have you decided to do as an organisation? Are you with us on this journey? And if we can get even 10 or 20% of our Alliance partners on the journey with us on this first year, we're doing an amazing job. We can beat diabetes together. We can take the heat out of diabetes.
I'm going to ask my panel now, please. Would they come up? Just come up, my panel. You can see we have 5 wonderful people who are going to talk and tell us about prevention, what they've done, not over the last 10 years, Glenn, the last 120 months. Do the maths. I'm talking about the same period. Now I've got 6. This is interesting. Just talk to yourselves. Okay, we're going to ad-lib a little bit here, so this is going to be good. No, we'll get through it. I looked up the word champions, and if you look it up, they've got a definition of noun and verbs and what it really means, and I'm really taken back when we try to get an understanding of words. And when I looked at the word champions, you are champions, and that's not just lip service. That's about saving people's lives and future generations. We heard just a moment ago from these eminent 3 that were here. You're at the coalface. Janine, what's happened for you in that journey?
Well, I've been with Glenn pretty much from the start for the last 9 years. And when we first started with prevention, we realised that health alone can't fix it. We need the whole community to come together and change the environment of Western Sydney. And that means that our residents have got access to healthy food and know how to cook. Because cooking's missed a generation and a whole lot of families here. They need access to physical activity, and as Professor Leda says, we need to give people a choice so that people can do something that fits in with their life that they're actually going to enjoy. that there's a reduced reliance on car transport, because everyone who works and lives in Western Sydney knows that people in Western Sydney drive pretty much everywhere. And most recently we realised that we need to increase the canopy cover. So what we did was we started putting together an alliance because we realised that all the sectors needed to come together, and we were very fortunate to have the Department of Premier and Cabinet assist us, so that we were able to get leaders from all sorts of sectors to come along and join the alliance, and then get people from the government, non-government and private organisations. And it's grown over the last 10 years, and we now have 140 organisations as part of our alliance.
And if I can say, and not to single anyone out, but Blacktown Workers or Lifestyle Group have been absolutely amazing. And I know that our chairman is here and our CEO, but they have been amazing in hearing the story and stepping up to the plate. I think that's a fair summary.
That's absolutely right, Jin. We've held so many functions here, and also they've made a commitment of $100,000 for over a 5-year period each year, and that's been absolutely a game changer, that we've been able now to look at things that we could never look at before, and that included things like the 2 kg campaign that's already been spoken about already tonight.
And I'm just watching heads acknowledge that. I just saw Stephen acknowledge the 100,000, saying that's a commitment of 5 years. We've bought some time. I'm looking at prevention and I'm saying step up, step back. We're stepping up, and I want to applaud the board and also your acknowledgement of that as a commitment. Janine, thank you. You've driven that so well. As I say, I'm ad-libbing a bit in a sense because there's 6 here, but we'll get through it, okay? Now, Doug, tell us about you and what you're doing, an amazing journey. Thank you, Janine. Yep.
Thank you. My involvement at present has concluded. However, I was involved early on when Janine and Glenn came to me, and I was working in the Department of Premier and Cabinet in the Western Sydney office. They, as with many people who would come through our door, would proceed to sort of give the description of what they were seeking, what they hoped to achieve, and it just struck me immediately that this was something that could really deliver for this community. And from my perspective, it just ticked so many boxes. It was an opportunity that could demonstrate the power of government working with the community and being able to achieve something that leads to long-standing change. I sort of played the role of being the, shall we say, the person who wanted to challenge them and to test the case so that they had to prove the case. And one of the things I did was actually say that we've got to actually develop an economic model associated with this so that we can actually say to decision makers that this is actually a genuine win-win situation. If you invest in primary prevention, you will actually save money because you won't need the resources in healthcare down the line, and at the same time you will then proceed to have real benefits for citizens in this area. Benefits so that they don't have to go down and be faced with the sort of issues that were being talked about earlier, like amputation, etc. The other thing in which I thought is so powerful about what this particular initiative has done is it has brought together so many groups, because it again is one of those situations where the sum is greater than the individual parts, and not one of the individual parts can actually solve the problem.
Do you still have a great passion for what you're doing?
I certainly do. I've moved on from this particular area, but it's something that I think when it comes to this area is really crucial. My personal ambition in life is to actually see positive change, and this is an example of positive change.
And while I was tying that together, we've got commitment with regards to the 100,000 a year from that end, from food. You're talking of another dimension, and your commitment is really important within the group and prevention. Thank you for sharing that with us. Professor Thomas, I knew I'd get you when you're having a drink of water, so sorry. Thank you for being here.
Typical academic not able to turn on the microphone. Thank you very much, Jim, and thank you very much, Glenn, and to the team for inviting me to be back here. 10 years. 10 years! Where's it gone? Wow, gosh. I have moved to the University of Sydney recently as the Professor of Cities and Planetary Health, and since, maybe one of the first years that I stepped foot on this brilliant, beautiful country, I had the serendipity to meet with Professor Glenn Mabley over in New South Wales Parliament, and I presented some work and which basically showed this, and I still remember it. It's probably, unfortunately, a lot worse now, but if you're in Mosman, Manly, these sorts of affluent suburbs in the North Shore and eastern part of Sydney, prevalence of diabetes is about 2.5%. You get on the train in North Sydney, you go over to Strathfield, lovely place, but the prevalence of diabetes is about 6% there, so not great. You stay on the train, you come to Blacktown, but you also maybe go over to Liverpool, or you go down to Campbelltown, and the prevalence of diabetes is at least tripled or quadrupled from where we started off with. This is not good. And it tells us something which is, Steve has already mentioned, and what Norman mentioned earlier. We are in part where we live, and we are to some extent influenced by when we get off the train, what's around us. It's 9 o'clock and we don't want to cook, and we've got kids waiting for us at home. We need to put something hot on the table, and it's dependent upon what's around us. So Glenn and I, supported by Walt, supported by both Steves and others, we mapped what we called food deserts across the city. In a nutshell, areas where it's really rather difficult to go anywhere apart from the big McDonald's sign or whatever it happens to be. And bombshell, more food deserts in the western suburbs. And second bombshell of the night, if you're in a food desert, average BMI tends to be a wee bit higher. And not great. In the meantime, some of the work that Glenn and I and others have been doing has been around tree canopy, which Janine mentioned. Here's something which is perhaps less intuitive. What we've found, and we've been able to replicate this in studies done around the world, is that the more tree canopy you have and the more parkland you have nearby, the lower are the odds you have of getting diabetes over about 5 or 6 years. In Sydney, we calculated at about 31% reduced odds of diabetes over 6 years. Taking into account differences in age and income and education and over different types of status, wow, not necessarily as intuitive as you might think, but perhaps, if we think about it a little bit more, standing on a tree, it's a bit cooler. It also helps to wick away the air pollution. A tree-lined street is a more pleasant street to walk down or cycle down. You're no longer as car-dependent upon those short journeys. Perhaps going to play cricket, for example. You don't need to walk. You don't need to drive there. You can walk there, for example. And then, of course, the thing which I keep on going hammering about, which you don't need to know about, which is you're more physically active as you go about this as well. So what that means is we not only all have a role in this room to play in beating diabetes together, but the people who are actually getting out there, donning their big hats with their sun cream and putting trees in the ground, they're also doing an important part of this job. And we should salute them and support them and get out of their way to make sure that we make Blacktown a really green city for now and for future generations.
Thomas, thank you for that. Very passionate. And I think it dovetails well into our next speakers. Simon, I want to go to Simon, please. Tell us about you and the Heart Foundation.
Sure, thanks, Jim. So the Heart Foundation has been involved with the Alliance, I believe, since its inception, with supporting through the Koori Cook-Off, which was well before my time. But our main thing, and I'm sure everyone in this room knows that the risk factors for cardiovascular disease and diabetes are very, very similar. And so picking up what Tom said, the cardiovascular risk calculator that was released last year, postcode, is now a weighted risk factor for cardiovascular disease, and similar for diabetes here. And so At the Hut Foundation, we're very much in line with everything that Tom was just saying about the importance of the built environment and the availability of healthy food options and meeting people where they are. It's all well and good to try and instruct people and inform people to eat healthier, but if they don't have the options there, if the Big M is in front of you, 6 times a day, it's just makes it so much more difficult for people in the region to make healthy choices. And so, access to green spaces, safe walking routes, the ability to have active transport options when you're doing that short trip to the shops. It really makes such a huge difference in making sure that the community is physically active. And as everyone has already touched upon here, the importance of the community and the role that everybody can play in the prevention of a variety of chronic diseases. And so the Heart Foundation, our main program out here is our walking program. We have a walking plan that you can get individually through our website, or you can join a walking group. Pre-pandemic, pre-COVID, we had, I believe it was more than 20 walking groups from GP clinics in Western Sydney, and most of those now are not functioning anymore. So we would really love to see them back up, and these are community groups that get out together on a regular basis. They join the local community. So anyone can, any host organisation or any individual, or we have a couple of elected officials in here. We could be the first person to host a walking group from your electorate office would be fantastic. And so we'd love to see those really just the growth of those throughout this region here.
While we're talking about prevention, I challenged you. Tell the audience.
That's right. So Jim and I were talking before, and anyone that starts a walking group in Western Sydney, let me know, and I'll be at your first walk, and then I'll come along to your 100th walk as well. And so we'll do everything that we can to promote the group through our networks and to really support you to support the community.
And Norman, given your vast audiences and so, I would love to see some triangulation there to actually have that. You said, Simon, that you would come to every first
Yes,
walking group.
absolutely.
So that's the Heart Foundation, if I can put that there. I'm a person, very simple. I like things, I'm task orientated, and I like dates, and I like a job. And so to me, there's a challenge, but a very positive challenge. 5 more minutes to go. Matthew, please.
Hi, Jim. Hi, everyone. I love Blacktown City. I love the country we're on, the honour to work on Durrock country, but it's the people. Born here, bred here, went to school here at Doonside. My folks still live up at Seven Hills at Sevo. Love the place. Came back to work here with the community, with the partnerships. Spoken a couple of times tonight about partnerships. My day job is with local government, and no party can do it alone, but through that partnership, we can do things and great things. I love the power that there is in the partnership of community voicing their need, their requests, their desires, partners, stakeholders, and there are many in this room, elected representatives, identifying that need and responding to it and addressing it. We've done a lot, but there's a few to go. I'm really encouraged by some chats I've had in the room, and you've spurred me on again, thank you, around the simple things we can do, whether it's making our public open space more accessible. And it sounds simple, right? Public open space for the public, of course it should be. And every member of the public should be able to access it, play in it, walk in it, throw a ball in it, talk in it, learn to ride a bike in it. And we're doing some things out there. One of them, led by Dr. McDermott in the room, is to unlock Prospect Reservoir. We don't have the coastline close to us and our families to swim, to learn to swim, but we have this water body there that is there, it's public land. Yes, it has other functions, but there are precedents for those water bodies to be unlocked and to be swum in, walked around, picnicked adjacent to. Local government, and my role as an officer, is to respond to the community need that we hear and that we're directed to respond to through our executive and councillors and mayor. So really encourage us to empower our community to voice their needs. And there's organised groups out there that have a strong voice, and sport is great. It's 10% of our community. What about the rest of them? How do we empower them? help them get organised to voice what they need. Whether that's a walking path with a seat, with fresh potable water and a tree, that's achievable. But we need to hear that and respond to it accordingly.
And Matthew, there seems to be a theme there, talking about those things, not only the medical aspects, but those things which contribute to the betterment or worse of the person. Sarah, I just want to say welcome, and you're going to be taking on another role within the organisation, and I say on behalf of all of us here, thank you for taking that really important role on, and we join you in all the success. Can I say thank you? One of the things about being a leader is today is not the end. You have to have the passion, as you're saying, Doug, to continue even more now, to continue in the journey of creating a better life. And we're going to hear from some mayors from the Hills and from Cumberland, and I know Norman's going to talk to other parliamentarians, particularly our state. But I've been very impressed with the enthusiasm and the passion of each of you. Would you please join with me and making our guests and colleagues very welcome for their contribution tonight. Norman, this is your part now, but can I just ask, can I sow one seed amongst the academics in the room, Norman? We talk about all these things. Where are the PhDs, the DBAs, the Masters research programs, not in medicine, but in doing things which can have an impact? And I'd love to see some work in that. Our Deputy Mayor talked about a change in the syllabus today. Our Deputy Premier about the syllabus in education. Where are we in that equation? Thank you.
Hello, there's a revolutionary technology that's changing the way we manage diabetes. It's called CGM, and it's a game changer for people living with diabetes. CGM stands for Continuous Glucose Monitoring. This technology measures glucose levels continuously throughout the day and night without the need for frequent finger prick tests. Instead, it uses a small sensor placed on the skin, like the back of the arm, that reads glucose levels in the interstitial fluid every minute. The sensor is discreet and painless. It communicates with a reader, which can be a mobile phone or a dedicated device. This provides a comprehensive view of glucose trends. CGM provides a far better view of a person's glycemic profile than traditional finger prick tests. It helps us make more precise medication adjustments and lifestyle recommendations with diet and exercise. This continuous feedback is invaluable for effective diabetes management. Time in range, or TIR, is one of the key metrics CGM tracks. It shows the percentage of time a person's glucose levels are within the target range. Studies show that even a 5% increase in time in range can significantly reduce the risk of diabetes complications.
Before I got these sensors, I'd have to finger prick myself to get a blood reading, and what I've found out since having the GCM put on, I was getting a correct reading but it was at the wrong times. So I was getting a higher reading when I shouldn't have with my medication. Due to the tag on my arm, I've now come down off a lot of medication. I'm not taking 2 tablets. I'm down to one tablet and 1 tablet for cholesterol, and I've reduced my insulin by 1/3. Just by taking this and having a proper understanding of how food affects me, and through my physical things in life and work, and being able to have real-time readings of it is what has allowed me to go off these medications and just to properly regulate myself. This thing in my arm has been a real game changer. I feel so much healthier for it, and the few that I've had 3 here from the hospital, I'm ever so thankful for it, because it has honestly changed my life, and having a proper reading. As I said, when just doing the finger pricks at the wrong times give me 2 higher readings, like I may have just eaten or just before I eat, and the blood levels just weren't right. So I haven't been able to check before I eat and after I eat, an hour after I eat, without having to finger prick myself all the time and have it constantly there, just by using the phone or an app. It's been such a blessing. Very easy. You just got an app on your phone. Keep the app running on your phone, and all you do is put your phone to your arm. Just wait a second, and it goes bip bip, and then it has your readings there. It's good with the dietitians with the hospital, and wherever your medical team is. You just before you eat, you go to do a reading. You punch in on the phone what you eat, how much you're eating. Then you have your food, and then you go back to your arm, and it'll tell you how you've spiked and whatnot. And then you can consult with your dietitians, and because you've written down to them what you've been eating, they know when your sugars are spiked, and then they can get back to you and help you with your diet, which will help you with your blood. It's just fantastic. It's been a game changer of my life. In all honesty, this thing has been a game changer in my life. I come here of my own free will to do it, just to try and get the message across of how much this has changed my life. Thank you very much.
Despite its clear benefits, CGM is not yet widely accessible to everyone who needs it, particularly those with type 2 diabetes. In Western Sydney alone, the diabetes epidemic is growing, with nearly 13% of adults living with type 2 diabetes and 38% at high risk. Managing diabetes costs over $18,000 per patient annually, totaling $1.8 billion in our region alone. By subsidizing CGM, we can improve health outcomes and reduce these staggering costs. CGM should be a standard of care for all individuals with diabetes, not just those with type 1. At Western Sydney Diabetes, we've integrated CGM into our model of care with remarkable results. Among 100 consecutive patients, in 3 to 6 months, we saw an average HbA1c reduction of 1.4% and an increase in time in range from 46% to 73%. The incidence of hypoglycemia has notably decreased, enhancing overall patient safety and well-being. Now, we are calling on the federal government to support the subsidization of CGM for everyone with diabetes. This technology not only transforms individual lives, but also offers significant economic benefits by reducing healthcare costs and preventing complications. CGM is simple, convenient, and much less painful than finger prick testing. It provides a comprehensive view of glucose levels, allowing for more precise medication changes and lifestyle interventions. It enhances self-management, motivates healthier choices, and speeds up reaching target glycemic control. Let's make CGM accessible to everyone who needs it. By supporting CGM, we can improve lives, reduce healthcare costs, and lead the way in diabetes management innovation. Thank you.
Very much for that video. General practitioners are the cornerstone of the Australian healthcare system. You can't do effective system change without general practitioners being involved, and they've been key to the success so far of Western Sydney Diabetes. And you're going to hear from 3 GPs who are doing different things in this space but making major contributions. Let me introduce Dr. Shanthini Seelan, who's a GP at Bridgeview Medical Practice. Just come up, Shanthini. Kenseng Lim from the Mount Druitt Medical Centre, and Prashanta Malik, General Practitioner of Walters Road Medical Centre and the Barber Boulevard Medical Centre. Thank you very much to all 3 of you. Being GPs as opposed to non-GP specialists, you will actually know how to turn on your microphones, which is going to be great. Shanthini, you've been involved in the Healthy Living Toongabbie. And I talked earlier on about how communities can solve problems. Just get into the detail here. What did you do, and what results have you had?
Thank you, Norman. Healthy Living Toongabbie is a community-based organization. We are actually a little fire that was lit by Glenn Mabley. Glenn truly believes it's community all the way. Diabetes is a community-based disease, and it has to be managed in the community. And we thought, and Glenn lit a fire, and he said that, why don't you all gather a group of really interested individuals from all walks of life, all bound with a common goal of bringing up awareness of diabetes in the community. So we have a group of 25 individuals. We meet every month, And all of us we have different skill sets that we bring together, and we focus and we work at grassroots levels in the community. And this is what we do. We bring about awareness of community, of diabetes in the community. We are based in Toongabbie. It started in Toongabbie, but doesn't mean that we are just focused there. We look after the whole of Western Sydney, you could say that. And over the 5 years that we've been in existence, we have done so many forums on diabetes, really interesting forums. And during those dark, dark days of COVID, I have to plug this. Thank you, Norman, for CoronaCast. It took us through COVID, and it saved my life, at least. Thank you. Well, during the dark, dark days of COVID, we went on, we started doing webinars, diabetes and COVID, and we had a lot of success, and we reached out to a whole group of people out there who were very, very confused and very scared. And through this method, we managed to bring about a lot of information about diabetes. And we found that when we do community speak, when we speak their language, they listen to us. Our latest...
Because you've been focused on the Tamil community in particular.
South Asian, because when around where we practice, there's a huge South Asian community. A lot of them have recently arrived, a lot of first generation migrants, and a lot of them have refugee backgrounds.
How did you find, it's all very well to have health system leadership. How did you find the community leadership? Because that's the key to sustainability.
Yes.
How did you find them?
How do you mean, like approaching?
The people within the community who are going to lead this and actually almost take over, which is what I assume has happened in part, is that you can step back a little bit and the community is taking ownership.
Exactly. We found that we had a lot of individuals who shared the same ideals as us. We had a lot of, we functioned under the auspices of Western Sydney Diabetes, and they provided a lot of support for us. We wouldn't be here without them. And of course, our PHN. And the best thing is to find people in the community who really understood what was happening. And they joined us. There is no money involved here. This is all a not-for-profit organization. We all volunteer our time. And when we find that when we approach the community, talking to them from their level, they really understand what we do. And our latest forum is called Women's Health and What Men Should Know. It was a terrific success.
Is it scalable? In other words, it's fine. You've got the enthusiasm. Glenn lit the blue touch paper and retired to a safe distance to allow you to get on with it. But is it scalable in terms of the whole of Western Sydney?
Yes, most certainly.
How?
Well, it's just that I can speak for myself, and I think there is a Filipino group as well, servicing the Filipino community. There is, all you got to do is really understand how bad diabetes is, how serious this epidemic is. It's threatening to overwhelm us. Unless we get the community involved, unless we actually reach out to the community, we're not going to win. It's going to be an uphill struggle. So
that drives that community impetus.
The community spirit, yes.
Can the I'm still surprised when I say to somebody who's a GP leader in their practice, so how many people have you got with type 2 diabetes in their practice, and they can't tell me?
In my practice?
No. Yeah. I was actually moving on to Ken there, could get onto his pet bear, which is data. It always surprises me that I find GPs who can't, but you will find practice managers and people like you who say, well, I've actually got 417 people with type 2 diabetes, and I know what their HbA1c levels are. How critical really is data to all this in the general practice setting?
Yeah, so I mean, it's interesting because that's actually the question I ask people, but I want to know what their practice is like. But 492, 12 of them have an HbA1c greater than 10, of whom 2 of them are probably for medical reasons, and the other 10 are actually more for patient activation and other reasons, where the most common comorbidities for those other 10 are actually mental health. So about 14% of our adult population have type 2 diabetes. Bit of a data nerd. I don't know how far you want to go.
Well, what I'm trying to drive to here is it's fine to have the enthusiasm of GPs such as you three, specialist general practitioners such as you three, but you need systems in place to actually make this work. So you get community activation. you need the right system. So I'm asking you really, what is the system that needs to be in place in general practice to make this work so that it's easy for GPs to do it rather than hard?
I think that we often think that we have to find new things, but the reality is actually we've got the systems we need. It's about how we use them rather than whether we don't have them or not. So the data analytics systems we have, and a lot of this is through the PHN licenses and things, are actually very sophisticated as they stand. And they're sophisticated enough to allow us to find the thing which gives that practice team purpose and meaning. So when I refer to the fact that 14% of our adult patients have type 2 diabetes, that's actually not drives the practice team as much as the fact that when I say 11% of our patient population have a greater than 20% risk of hospitalization in the next 12 months. And we know who they are. And we can work out what combinations and conditions they have, and no surprises. Diabetes is one of the big things, but if you have diabetes and chronic kidney disease, that immediately jumps your risk up by 2 to 3 times, and then we keep adding it in, and we can really refine this one very dramatically. So when it comes down to the purpose, the data actually drives that purpose because it's visible, it's dashboards, we can see those changes month by month, and we can actually see it right across the region. And even in fact with things like Glenn's work, we can actually see changes in prescribing patterns as well. So the data does underpin everything, and it drives behavior, but it also acts as one of the incentivizers for further change.
I mean, you and others in Western Sydney have been pioneers in creating, if you like, a new system of general practice, where it always really annoys me where all you ever hear is negativity about general practice, and then you wonder why medical students don't want to go into general practice, because all they ever hear is a moan, and people such as yourselves, all three of you, have this very positive attitude and are changing things. But one of the barriers to change is indeed reimbursement and getting reimbursed for this. So some of this is out of the goodness of your heart and you want to do a good job. Moving forward, what needs to change in reimbursement so that there are financial incentives for GPs who may not be connected right now?
So you've come to really the third element of what I would see, which is raise, train, sustain. And sustain is how do we keep this system going on? Reimbursement is central. Part of it is actually recognizing that the traditional way of doing care, which is one-on-one, one patient, one clinician, is not necessarily the only way nor the best way. Second thing is recognizing that a lot of the work is actually behind the scenes. So reimbursement does need to have a couple of elements. One of them is how do we support the behind the scenes work, the data governance, the data improvement, the systems improvement. But the second one is actually broadening the methodologies by which we deliver care. So Shantini talked about some of the community work. We can actually go a step further and say, what about if we systemize that into shared medical appointments? And then we actually find a way that we can scale it. So instead of one-to-one, we have one-to-manys. There is, of course, another element, which is how do we pick which person or which consumer is going to fit best into one pattern versus another. And that's another piece of work, again, which is not currently reimbursed nor supported. That's looking at the concepts of patient activation as well. So there are multiple elements, but from a purely Medicare perspective, I think it does have to mean we have to look at a blended system. It does have to be weighted towards the risk and needs in communities, and we can actually define complexity in a few different ways. Currently, I quite like the idea of hospitalization risk indices, but we can look at multiple things, but postcode has to be a part.
Prashanta, when you talk to general practitioners who are not necessarily engaged with the program, they say, I haven't got the time to get involved in case conferencing. You're now a believer. What got you to being a believer in a sense? Because you may well have started off with that kind of skepticism yourself.
So look, we involved with Professor Mably's team since 2016. So I remember that that time case conference used to do, the registrar consultant used to come to our practice. But, whether thanks or, not thanks to Corona or COVID, then we started Zoom meeting. That's a great way. We learned a lot of things from Professor Mably's team. So that was a really good motivation for us. So with all our team, all the general practitioners, we discuss with our patient, because it was so difficult before sending the patient to the private consultant. Patient couldn't afford to see the private consultant endocrinologist. It was very difficult. My training I did in Westmead Endocrine outpatient clinic. I was working there. Often I saw that it doesn't reach up to GP, general practitioner. We used to see the patient in the clinic, but we found that often patient coming back with a high HbA1c, that looks like that something is not working. And in fact, I never wanted to be GP, but I love my job now. So what we learned from this case conference, this is a teamwork, and our patients love this. Especially mentioned the CGM machine, especially we mentioned that case conference, and I never saw any patient of my diabetic patient did not turn up for the case conference. Because this is not matter of what I'm doing, it's a whole team is doing. You know, the previously mentioned the primary prevention team working hard, education is going on in the community, and then all these people are coming to us, and it's much easier for us to work with them now.
So do you feel that you've almost become a subspecialist in general practice endocrinology?
I think we can do quite, skill is significantly improved. So I can manage diabetes, I can start insulin. I know what is the when to reduce the dose, what to do. I can actually share all my knowledge with my register, which is great. I feel proud myself is because of Professor Mabuli's team. And I'm really proud of the Western Sydney, part of the Western Sydney, because we are very motivated. We decided, that we have a monthly case conference. We look at our statistics data because we got a 432 patient, type 2 diabetes.
I'm impressed.
Yeah, and so we review.
How many are you beating Ken and the people with high HbA1cs? Are you doing better than him?
We actually see that every 3 to 6 months. Like I can tell you something. So last 6 months, probably there was this somewhere that the PenCat you can pull out 8 to 10, and then we looked at that. 6 months time, 8 to 10. We did.
Sorry, just to explain for people who might not understand here, there is two or three technologies now where you can actually go into the back end of your general practice and examine how patients are going without bothering the general practice and see the quality of care.
Yeah, so we saw that we reduced somewhere like a 4% reduction within 6 months of those from the 8 to 10, they dropped to less than 8, which is great. We used to look at the data with the practice manager, we share with the other doctors. So we say, wow, we did something, great job. And
so Shanthini, do you share that professional, if you like, excitement about what this is done for?
Most definitely. I find that the case conference has done this. It has bridged the huge chasm between primary and tertiary care. There is so much of exchange of information that tertiary care now knows what trials and tribulations happen in general practice. They understand fully what our time constraints are, and we in turn learn and understand and get so much knowledge from them. So it's empowered us. Like I really echo Prashanta, and it's made us more comfortable, because previously diabetes management was very fragmented. Once the patient disappears into the bowels of this hospital care, we don't hear anything back from them. So now it's totally different.
My final question is that Western Sydney and Southwestern Sydney has the highest Aboriginal population in Australia. 50% of First Nations peoples go to mainstream general practice, and others go to community-controlled community-controlled health organisations. What is the challenge? And Shanthini, you've worked with the Tamil population, you've empowered them, which is exactly what Aboriginal communities do with community-controlled health organisations. How do we get it better for First Nations communities within mainstream general practice?
I think mainly it's all to do with how we got so successful in what we were doing. When I say Tamil, it's actually subcontinental, the whole thing. It's actually being very culturally sensitive, talking in their language, making them feel really welcome, that whatever they come to us, we are there to look after them. That is how we approach it. It's very tailor-made. Western Sydney is very vibrant, very exciting, but it's very multicultural. So it's exciting to live there, but you have to tailor-made your approach to the community that you're looking after.
Ken? What's your view on this, Ken? Of
Sorry, I think
providing a better care, a better service, more activation in the First Nations communities who go to mainstream general practice.
So I think there's a really classic, or rather one of your first points there was quite telling, which is that 50% of First Nations people do go to the Aboriginal control centres and 50% don't. We, in our practice, are literally 200 metres down the road from one of these art shows. So what's interesting, of course, is why someone goes to us and not to the other. And that's probably at the heart of it, which is that it's not one community, it's multiple communities. And these multiple communities, and when we think about multiple communities, we do have to, and another one of the words you've used is tailoring, we do have to tailor and work with those individuals within that. And I think the same applies for all cultural groups. So it's the same as saying Pacifica community, which is not one group. It's the same as saying any other, saying Yugoslavian community or anything else. So I think that issue of sensitivity, working with patients and patient groups, has got to be the key.
Could you please thank our general practice panel? So for anybody who believes the headlines that it's all hopeless in general practice, you've just seen examples of how that is absolutely not true. It's certainly true that there are challenges, but very satisfying specialty within medicine. Now, government. We all want government to do something and solve our problems. Well, we're going to get some people up from government and see what the government can do for us. Although they're going to quote John F. Kennedy and say, well, don't ask what we can do for you, what can you do for us? Stephen Barley is the local member for Blacktown. Hugh McDermott is the member for Prospect. Mike Friedlander is the federal member for MacArthur. Was my resident when I was a registrar in pediatrics. He survived that, amazingly. The Mayor of Hills, Peter Ganjemi, and the Cumberland Mayor, Lisa Lake. So, Peter, all politics is local. We tend to ignore local government when it comes to health and well-being, although I think local government would consider it core activity. Let's just start local and we'll move through the system. There's a lot that government is not doing here, but there are things that they are. Just talk about the things that you're doing, but also the challenge in front of you.
Well, it's certainly a big challenge, as we've heard here today. Here in Western Sydney, we know the demographics, we know the numbers. It's an increasing epidemic that all levels of government need to do more about. As a council, we're a big organisation. We're intricately linked with our community, and so we can use that size and our ability to, we can advocate for incredible causes like this. I remember when I was elected mayor, one of the first meetings I took was when Glenn and Janine came to my office, and since then they've invited me to a number of events and asked me to do a number of things, and generally what Glenn's asked me to do, we've been able to do and assist. So we can obviously as a council promote incredible initiatives like this. We can send messages to our residents what we need to do and what are things that our residents can do. We also
which is all great, but I want to really get to picking up on Jim's challenge about discomfort. One of the things I did, I'm not necessarily proud of it, but is that I was the doctor on, the media doctor on Biggest Loser. And for those of you who don't remember or never heard of it, this was a show, a so-called reality show on Channel 10, which you got people who were obese, and the person who lost the highest proportion of their body weight won if they survived to the end. It was a lot of criticism about it, but one of the things that we were proud of is that we went to the second heaviest city in Australia, which wasn't Blacktown. It was Ararat in Victoria, and the heaviest in those days was Bundaberg in Queensland. Now, there were no walking tracks. Woolies and Coles did not stock fresh vegetables in any great quantity. And it took this juggernaut coming to town and actually giving money to the local council to actually build a walking track. And part of the barrier were local councillors. And I've talked to local councillors who just don't understand the environment and health. So this might be a career-ending question for you.
No, it's not.
To what extent do local councillors understand this stuff, that actually planting trees is good for health and well-being and is going to reduce type 2 diabetes?
Well, on the Hill Shire Council, we've got a great team of councillors, all 13 of us, and we absolutely understand. No, but we absolutely understand these issues. And in this term of council, we've made it a top priority to increase the number of facilities in our recreation network, but also the quality of them. So, for instance, in this term of council, we've spent a record amount in recreation facilities, things like our Waves Fitness and Aquatic Centre, which is a nation-leading aquatic facility in terms of its quality. That's encouraging people to get out and about. We've done a lot with our networks of footpaths and cycleways, such as the Greenway Link. You can cycle from Bella Vista to Rouse Hill without leaving a footpath, for instance, without having to cross too many busy roads. We're doing a lot of tree planting. So, for instance, along Samantha Railway Drive, we've got some grants from the state government for that. Thank you, Stephen. And then also we do things like Plant a Tree Day. We've got one in the Gables just this weekend, for instance. So I will be certainly telling our volunteers there this weekend that by doing this, you're doing not just in work for the environment, but also for health and well-being. And so these are all little initiatives that we're always looking to do more of. And it's very exciting, I think, the direction that we're heading.
And Cumberland? Lisa?
Yes. Well, everything that Peter's doing, of course, is matched through Cumberland Council's work with a number of planning proposals that have been undertaken only this year. There's been 2 where we've recognised that in rezoning areas, it's not enough to put further density in and build further houses. You have to adequately accommodate green space. And if COVID's taught us anything, it's the value of having public open spaces. But the strength
Are developers playing ball?
Yes, because that makes their properties much more attractive, particularly if they're building home units. They recognise that public spaces are critical to people wanting to live in their developments. But the point I wanted to make about local councils particularly, and perhaps building on what Shanthini said earlier, is that councils have the function of being very good coordinators. And if you want to get a message across about healthy living, about good diet and nutrition, councils know how to contact all the organisations that can assist with getting that message through. And in a place like Cumberland, where you have people from about 115 different countries, 65% of our people speak a language other than English at home. You need to know who are the leaders of various ethnic organisations. You need to know who are the leaders of communities of faith, and of course all the leaders of all the sporting organisations. And through that, you can use that network to get an effective message. And at the end of the day, when you looked at what happened with COVID and the work that we had to do to convince people about the necessity to be vaccinated, it was only through working through trusted community leaders that we were able to be successful.
So you're an obvious partner in something like this, but not necessarily a natural partner because you're not part of the health ecosystem in a sense.
Exactly. So we have to be the link, and I think that's where councils can come in. We can be the link between the health experts and the local people, and we can encourage meetings and set up venues and do what's necessary through, I mean, we have 8 libraries that put on workshops right through all the school holidays particularly. We've got 5 swimming pools. We've got hundreds of parks and sports grounds, many of them now being built with outdoor gyms. We've got the facilities and we've got the networks to be able to encourage a good community of practice.
So, doing good work, but looking forward, what are the elements in the system that need to be put in place to actually to minimise, if you like, the missed opportunities? Because not everybody would know what you're doing and how the facilities that could be taken advantage of.
Yeah, that's right. So communication is the key, and communication in languages. Often councils talk about putting things out. They proudly say, well, we get all this information out in the top 5 languages. But I think in an issue like diabetes, I think you have to look to some of the smaller communities, target the ones where you know diabetes is particularly a risk, a health risk, and start working in language through their trusted community leaders to get that message through. But the good thing about councils is we have people who do that every day in all sorts of aspects, and I think probably we could be a very effective link.
So Hugh, we've got these various levels of government. Sometimes we tear our hair out at the various levels of government and the state-federal relationship, but states cop the bill for this, and you don't necessarily hold all the levers. But just give me your perspective of the role of state government in solving this problem.
Well, as everyone here would know, the health budget in the New South Wales is significant. It's the biggest budget, the biggest cost that we have as a government. And that reflects in every single state, more than transport, many infrastructure, or any other area. At the same time in New South Wales, we have a massive debt now of $187 billion. So we're having to manage that now as well. And cost of living pressures on families, particularly working families in Western Sydney, an area of Blacktown, is crippling. Whether that be tolls, whether that be the costs of rent and mortgages. At the same time, over the last decade, wages haven't kept up with that cost of living pressures. So all these massive things are impacting on our communities at the same time on our state government.
Nonetheless, you've got to spend money to save money.
You let me finish the answer, all right?
You're sounding like John Howard.
We've now set the scene of what's going on. That said, it has been record spending in health budgets for this last 12 months, because there has to be. Because particularly in Western Sydney, we have so many massive pressures on our community. Diabetes is one of the key parts of that. We talked about leadership, we talked about council, and I totally agree with everything which Lisa has just said. And in the electorate of Prospect, I deal with Blacktown Council, Cumberland Council, Fairfield Council, and Parramatta Council. All at the centres of diabetes in Western Sydney. All very multicultural, whether that be Middle Eastern communities, subcontinent communities, African communities. So the leadership in these communities is extremely important. At a state level, as far as government stepping up and making sure that there is a whole of government approach, whether that be at education levels with children, with their munch and crunch and other things, all the way up to the health budget and the health practitioners, and making sure they have the resourcing to make sure they can get out there and actually deliver the message, but also work with local communities, local organisations to fight the diabetes challenge. And making sure that we have enough health practitioners to be able to do this, whether that be those from nursing staff, doctors, nurses, practitioners in every level. Now, we've had 3 GPs up here in practices, 2 of them in the electorate of Prospect, when I've dealt with them before, and they work very, very well and very strongly together. The 3rd one at Mount Druitt, Dr. Lim is well known throughout Western Sydney for his leadership. But there has to be more than that. That they are the leaders, and they have to have a situation where they can work with council, where they can work with MPs, and they are supported to do that work. Same with the pharmacists. These are the leaders in front of our community when it comes to diabetes. What government needs to do is make sure they have the funding and the resources to be able to deal with that. And it's difficult. This last budget, we saw a significant cut in state government budget funding from the federal level because the feds are dealing with their own issues as well. Billions of dollars, and it's not Mike's fault. I know Mike fought for us, try to get the money
Everything's
back.
Mike's fault.
But, these is what we need to do. These are the things that are the challenges for government. We need a response of a government that will look at not just building infrastructure, not just building hospitals, which is what's happened in the past. It goes back to the days of Tony Blair, where you can build a hospital and put a plaque on it, nice photos. But if you haven't got the health practitioners and the education and the support to help patients, you will just have diabetes grow.
So Steve, some systematic stuff has got to change. So for example, the feds pay for general practitioners. And I've often wondered why state governments don't get over it and incentivize general practitioners to reduce demand on the system, which could solve a lot of the problems in terms of lubricating the system. But we seem politically hamstrung here, that that's the federal problem, and we're not going to pay for general practitioners to do this.
We've just given them a massive tax bags and everything else. All right, you get to it, but you know, it's just not true, that's all.
I was just about to say, I thought that was a nice Dorothy Dixon there. The state government in the last budget, or the one that just came down a couple of months ago, has actually, if a GP has about 80% of the patients on Medicare, actually don't have to pay the payroll tax, so which is really good. But also, just very briefly picking up one of Hugh's points there, the size of the health budget is over $30 billion, and that represents about 25.5% of the budget. So, and the reason I just want to highlight that, and as Hugh said, the debt's blown out to $187 billion, which means there's mega interest rates that we've got to pay on it. But that 25.5%, if I can just dwell on that for 1 second, if you look at the New South Wales government has been in existence this year, we celebrate 200 years. This is the first time ever in 200 years that more than $1 in $4 is being spent on health. So the question then becomes...
But not necessarily in the right way.
Well, exactly, but at what point, what are we going to say to patients, and this is the great debate, the uncomfortable questions that we need to pose, is how can we actually stop acute care and then focus on long-term care? If someone is sick right now, we got to deal with that right now. And that is costing us $30 billion. Then we have to add further to it. At what point are we going to say that education has to be cut? What point are we going to say all the other infrastructure and transport?
You hear this all the time, but the reality is, for example, in New South Wales, Victoria and other states, people have found ways of managing the waiting lists for, say, knee replacement, where physiotherapy-led clinics reduced waiting lists by 20% and more appropriate surgery. There are ways of spending money where you still provide acute care. Victoria, with an even bigger debt than New South Wales, is shifting money towards secondary prevention, community, investing in general practice, more than just relief of payroll tax. So the question is, moving forward, how do you convince Finance and Treasury that there are different ways of spending money?
Well, that's where, coming back to the original question of partnerships, we got to really listen to the experts like Glenn and everybody, yourself, of looking, the money is there. There's $30 billion. For the first time ever, we cracked the $30 billion mark, 25.5%. How do we reappropriate some of that money? There's a lot of waste in the system, you're 100% right. But as a politician, we're a little bit too far removed, which we need to get somehow people to be honest and transparent and stand up and say what parts of the health budget can be cut, what parts can be improved, and where should the money go. And just picking up on, if I can do a quick survey, and picking up on a statistic that Mike just whispered to me before we came up here. How many people out there, put up your hand if you have a favourite coffee shop that you know, that you sometimes regularly go to? How many people got a favourite coffee shop? So, I don't know, statistic-wise, how many did you see out there? About 50%, 60%? At least 60% of the people go regularly to a coffee shop. And if I asked you what the name of that coffee shop is, you would tell me. Mike was telling me earlier that with the, hopefully I'm not stealing your thunder, but that most people, if you ask, and there's some surveys down in Campbelltown Hospital, etc., when you ask who is your doctor, only 30% of the people knew who their doctor or who their practice is. So if we're really serious about health, if we know where our coffee shop is, but we don't know who our doctor is, that's the first step as far as what the state and local council and the federal government need to work together to make the primary doctor as an important aspect, which means we need to address, as it was talked about before, what is the financing of your GP? What's the appropriate way to be able to address diabetes, etc.?
Michael, you've had a parliamentary inquiry, you've made various recommendations, one of which is funding continuous glucose monitoring in type 2 diabetes, albeit only for people on insulin rather than in general. Well, that's another debate to be had. The question I've got for you is, this is a societal problem, it's a socio-economic problem, it's about food security, it's about incentives in the system. Your government, just like previous governments, has done nothing about controlling and regulating the global food industry. Why not? And you've not regulated advertising. So the core cause here, obesity, is a problem of the 60s, 70s, and 80s. And if you look at cohorts of children born, genes haven't changed, parents haven't changed, but obesity has gone up by 10-year cycles. And the smart brains in this area in the research say it's the global food industry that's done it. And federal governments, one after the other, have done nothing about it. And all they want to do is educate the public, which has almost no effect. You're welcome, Michael.
Thanks for that very easy to answer question, Norman. Part of our recommendations is looking at food labelling, looking at the food industry and how they can help. But if I can just go back to the beginning, you and I grew up in the transactional medicine age, the beginning of Medicare, following on from Gough Whitlam's Medibank, and very transactional medicine. That doesn't work in this age. This is the age of chronic illness, and we need to relook at our health systems, how they can deal with chronic illness. And the diabetes epidemic is a public health epidemic and requires a public health response. And the inquiry that we did, which took place over 18 months and required travel all over the country, from Broome to Burnie to Canberra to Cairns, all over the country. The solutions will be different in different communities. Now, I'd like to thank so much everyone, including the Western Sydney Diabetes Group, led by Glenn, for their input to our committee, and it was very valuable. For Diabetes Australia, for all the other people that contributed to our report, we made a number of recommendations which I have committed to making sure we will deal with. There were 23 major recommendations, and as a government we cannot possibly do all 23 all at once, but we will work through them and we will do it. The important ones are looking at the public health measures. That looks at food labelling. I mean, I'm reasonably health literate, but I go into a supermarket and I pick up a box of cereal. I don't know what the labelling means. I cannot read it, probably because my eyes are getting worse as I get older, but I cannot understand what it means in terms of what it will do to my health. We need to change that dynamic. We need to make sure that people are aware of the dangers of sugar-sweetened beverages. We went to Aboriginal communities and that's all the kids were drinking from the time they could walk were soft drinks. And we saw little kids barely big enough to walk holding big 2.5 litre bottles of soft drink, walking around drinking that. That's killing them. It's killing our kids. And we went to the Purple House, which is in Alice Springs. It controls all the remote dialysis.
But if you tax those drinks, the one way we've controlled tobacco is price of cigarettes. But you won't differentially tax sugar drinks.
One of our recommendations was a levy on sugar-sweetened beverages. Number one, to send a price signal. Number two, to get the companies to reformulate the drinks, because there is some evidence that even reducing sugar a small amount in those drinks will improve health in the general community. But I was going to say, we went to the Purple House, which does all the remote dialysis. They've got 80 remote dialysis chairs. They cost $200,000 per patient per year. The Northern Territory government, the West Australian government, cannot afford it. This is an emergency and it needs an emergency public health response. And that's some of our recommendations. It varies, as I said, from community to community. In Western Sydney and southwestern Sydney, we have some groups, and I've worked with our Tharawal Aboriginal Health Service for over 35 years. They're putting in place, with the support of the government, the state government, I must say, some really important things in providing healthy food for their Indigenous communities at a subsidised price. But we went to some remote communities, particularly in North Queensland, and I went into the supermarket in Yarranbar, which is about 150 kilometres west of Cairns. There wasn't a piece of fresh fruit in the place. There was nothing there I would eat for my lunch, and yet this is what the community was relying on. We need to change that dynamic. In Western Sydney, we have groups like Pacific Islander groups. They're well aware of the dangers of diabetes. They're seeing people with obesity and type 2 diabetes needing dialysis in their 20s. The vascular surgeons saw us because they are seeing a massive increase in amputation in people in their 40s and 50s. So it is affecting every area of medicine. It requires an all-of-government response, from local government through to federal government. I would disagree with a little of what I've heard about development. We need to make our environments less obesogenic. I don't see developers doing that at all. In fact, they try and get rid of every bit of green space they can to put houses on it. Certainly in southwest Sydney, that's what's been happening. It's barbaric what they're doing. People, as has been mentioned by Stephen Leader, I see families that spend 3 hours a day, the parents travelling. So when they get home, there's no way they feel like giving healthy food to their kids. We saw preschools giving very inappropriate food to the kids at preschools around the country. We see schools who used to provide lunches no longer affording to provide lunches. That's something that I think the federal government can change, and working with the state government. But Mark Butler, as health minister, got us to do this inquiry because he recognises the effects of the emergency, and some of the things he's put in place, like increasing rebates for case conferencing, increased rebates for allied health like diabetes educators, podiatrists, etc. They're making a difference. But we can't do it all at once. The cost is massive. We saw about the CGM, and I wore the CGM for a little while during this inquiry. I found it really life-changing. I don't have diabetes, but certainly cut down...
Made you read the food labels, did it?
Well, it did, and it also made me realise the foods that quickly put my blood sugar up. So they are very important technology, but if we allow that all the time for every person with type 2 diabetes, the cost at the present time is measured in billions of dollars. And we can't do that. So we need to work out some way of gradually getting access to the new technologies, and there are ways of doing it. For example, allowing it for 3 months a year or 6 months a year, and starting off by giving it to just people with type 2 diabetes and requiring regular insulin. So there are ways of doing it. But the federal government is trying to address this, and we will be working with the state government, and I've got the utmost admiration for Ryan Park. He actually, in a contracting state budget, he has actually done the best he could to get health funding in New South Wales, and certainly for Western and Southwestern Sydney, because he understands the issues.
Look,
I could talk for a lot longer.
No, lots to be done. Commitment there from the panel and at all levels of government. Thank you all very much for joining us.
Thank you.
So now there's the easiest panel of all, the future. What are we going to do? What are we going to do next? And on this lucky panel, we have Jasmine Ellis, who's General Manager of Integrated and Community Health, thanks to you, and Co-Chair of Executive Management Team at Western Sydney Diabetes and Western Sydney Local Health District. Anthony Newton, who is the newly minted CEO of Went West. He's been there all of 4 weeks, and therefore he now knows everything. Professor Di O'Halloran, who is chair of Went West, and tells me that she's cut back her workload by 50%, which means that she's only working 50% harder than everybody else at the moment. Glenn Maberly, who is the founder here of Western Sydney Diabetes. Rowan Clifford, who's Group Executive Health Services Operations Diabetes Australia. Chemo Zench, who's Corporate Vice President and General Manager of Novo Nordisk Oceania. And last but not least, Morgan Stewart, who's CEO of Workers Lifestyle Group here in the building that's hosting us. So thank you very much, Morgan, for hosting us and the commitment here. I want to start local, like I have with the others. What's the way forward? I mean, your business is understanding the community, being part of it, moving forward and making things better than they are. I mean, that's what the clubs like this are about. Talk to me about the future and your vision.
Well, ours is actually an interesting journey, and to quote Glenn, we've joined a revolution, not started one. We've been world famous in Blacktown for nearly 70 years, 55,000 members, and proudly partnering and trying to make effective change locally where we can. Our board of directors, and I shout out to Murray Searle, who's in the room tonight, and also our president, Jack Miller, and other board members. Strategically, our board's job is to provide us a direction and a sense of where things are going, and diabetes has been on people's radars for quite some time. We started things, and we don't like to just do the big check and then take a high five and move on to the next thing. We like to make commitments where we can. So we started a 5-year commitment to try and combat domestic and family violence, and we're in our 4th year of that, but we're in our 2nd year of challenging diabetes locally where we can. So our job as a member and community-based business is to try and provide a megaphone on this this scourge. It's a scourge like family and domestic violence. This is a scourge too. So our job is to try and maintain a commentary and a megaphone and try and make and measure change where we can. So we proudly started attending events.
The 2 kilogram challenge?
Yeah, the 2 kilo challenge is definitely part of that, and Steve Barley has been very vocal in getting that up and running, and I think that I'm about to make friends in the first ever walking group, I suspect very shortly after this meeting, which will be awesome. As long as it finishes and has perhaps a cap with 2 cups of coffee and a straw, I'll be okay.
But only in your favourite coffee shop.
Absolutely. So for us, it's about...
Do you know who your GP is, by the way?
Say again?
Do you know who your GP is?
I do. She's a wonderful lady up in the Hills Precinct. Kimari Obesikura, her name is. Wonderful Sri Lankan woman who is trapped in time, and she's been my doctor for 15 years, and she has not changed one single piece in 15 years, and may still be perched on the same chair that she's been sitting on all this time. But setting that aside, our job is to maintain focus, we think. So we've started a journey around food, around community, around megaphoning access, and asking people to be part of a journey, to come in and have blood sugar taken, to spend time with Victoria and talk about food, to spend time with Janine and talk about line dancing, which I will never in 2 lifetimes participate in, but I accept that it happens. And I'll just graciously move through to the next thing. But for us, it's...
Yeah, diabetes is looking quite attractive, actually.
It's hideously... nobody wants to see me line dancing for any reason. But what we are is committed on a journey, a 5-year journey. We're in the 2nd year. This problem is not going away, and neither are we. So what we're trying to do is just be good community partners and speak as often and as loudly as we can on this subject, and try and encourage people to participate in testing, then trying to get benchmarkable data so we can start. I'm a data nerd too, I like the data. And certainly that's where we're partnered with people like Noel Duncan from Sisu about having the machines in our clubs. We took that advice from Priceline, the sisterhood, who are great advocates in this space for testing. So we are trying to adopt a 2 ears, 1 mouth proposition, I guess, where we listen to good ideas and then try and advocate, and then we're not afraid to have a go, and if it works, it does. If it doesn't, that's okay. We just move on to the next thing. But we're trying to keep a forward focus on this problem that's not going away.
And Jasmine, from the local, the idea of the future from the local system level.
Might work. It's just me. We keep. Not use error. We keep going, Norman, is the answer to the future. And we remind everyone that it's not a health problem. Unfortunately, the pointy end sits with us in Western Sydney Local Health District, but certainly it's alliances like this is where we actually get the power to make the change. We know that the health budget, as great as it is and as big as it is, doesn't support initiatives like this because activity-based funding doesn't recognise initiatives like trying to sort out primary prevention. We've got a great health promotion team as well, Aboriginal Health Hub. We have to look for other ways to fund it, other ways to support each other, other ways to work better with the primary healthcare network, but also other partners like industry, because it's actually not a health problem on its own. We just deal with the consequence of it.
Have you worked out what the economic benefit is for every dollar you spend on a system like this, how much you save down the line?
From a diabetes perspective,
Yeah.
Glenn would be able to answer that one better. I know that we spend about $18 billion a year, and we know that our patients spend twice as long as a hospital with diabetes than they do without. So the problem is big and it's expensive.
Diabetes Australia is patient-focused, but it hasn't been prominent in this area, or maybe I've just got the wrong idea here in terms of Diabetes Australia, where you're focused on so many different issues. Are you really focused in the future on this sort of community-based, multi-sectoral, socio-economic, really what I'm saying is the upstream issues to do with diabetes?
I was actually reflecting on something that Matthew said before, which connected earlier. I actually spent my first 4 years in Seven Hills, and so this is sort of for me thinking about the past leading to the future. First 4 years in Seven Hills, chronic heart disease and respiratory conditions in my family, not myself, thankfully. So my parents' GP said, move, go to the Blue Mountains. They did. White, lower middle class, they've got family in the Blue Mountains. We moved to the Blue Mountains, fresh air, trees, active, engaging. At the same time, my wife across the M4, Fairfield. Fairfield was their safe haven from where her family had moved from overseas. There was no conversation about just up and move. Fast forward to today, my father doesn't have diabetes. My father-in-law has type 2 diabetes. So when I think about in terms of the community aspects, I think about privilege, I think about prevention, I think about equity. When I think about prevention, I think about the initiative with Western Sydney Diabetes and 18% of people through the screening initiative having diabetes, 30% with pre-diabetes in this community, Blacktown Hospital, Mount Druitt Hospital. I think about equity of access to food. We've talked a lot about equity of access to food, food safety, environment, walking out the street and feeling comfortable to go down the road and know your children are down the street and they're safe and comfortable and active. Equity of access to technology, obviously with, and thank you for Dr. Mike Freelander and the work as chair of the inquiry, the advocacy for access to CGM. People with type 1 have subsidised access to CGM, but there are a lot of people that are on insulin that aren't living with type 1. There are a lot of people that aren't on insulin that also need access.
But what's the role of Diabetes Australia in this? It's a big organisation with quite a lot of money.
So for our piece, and this is actually a really exciting month, it's started off with the inquiry. It's in the middle, National Diabetes Week, and ending with tonight, in my opinion, is an ask of $200 million over the next 4 years for equitable access to technology above and beyond the amazing effort and commitment that the federal government have already made. So for us, that would make a huge difference to communities that cannot afford something as, and I'm actually at the 14th day of my CGM right now, which is a privilege to have access to that. A lot of people do not have access to that. And so our ask is $200 million over the next 4 years for equitable access for priority communities, people under 21, Aboriginal and Torres Strait Islanders, and people on healthcare cards as well.
Shem, some people say, why don't we just put Ozempic in the drinking water here? And I've actually heard people arguing that we can go through all this agony. I mean, I know that this is not your aim in Novo Nordisk in terms of your involvement here, but it's the elephant in the room. And I've sat in rooms where people say, at $130 a month, it could solve a lot of the problems, rather than going through all this agony. Why aren't the GLP-1 agonists the answer here?
Great question. Thank you so much. Well, the company that I work for is basically has expertise on treatment, but treatment is not the only solution to diabetes. Yes, it's important, and we need to continue investing in research and innovation to create better medicines like GLP-1 analogs and Ozempic and so on. But we also believe in the prevention, and diabetes can be prevented. And Western Sydney is a hotspot in Australia when it comes to diabetes. The reason we are here in this collaboration is because we believe that diabetes can only be tackled through collaboration, through a united approach. And Professor Maybelline really showed that under the right leadership, when community partners, local government, industry comes together, put their resources and knowledge together, that has actually specific and positive change can be made.
So you've got a global program in the Novo Nordisk Foundation.
Indeed.
About cities changing the situation with diabetes.
Cities Changing Diabetes is a global program. We have more than 40 cities in the world. And Western Sydney is the only Australian example. And it's a truly globally recognized success story. We, of course, would like to expand and scale our work here, as well as looking for what we can do other places.
On the basis of data, which is the city that's doing best out of your 40 cities that are doing this?
Every city is different. Like we are discussing about every neighborhood, every local district is different. I can't comment on the other cities' success stories, but I can tell you we have a real working example here. It's a global benchmark, and our organization is fully committed to further expand that.
And generously funding it as well. But from where you sit and look across, what are the elements of success that need to be built upon for the future?
To me, for us, first of all, community-based solutions and building a place-based approach with different partners, looking at, of course, early detection, holistic education through the system, as well as, of course, looking at the overall early and lifestyle interventions that we have just talked about Three Lions and the food security. But it goes beyond that. We just need to bring more people on board, and we need to just expand and scale up what happens in Western Sydney, hopefully to other parts of Australia.
Di, you've followed this journey even longer than 10 years. What do you think needs to happen next? What are the building blocks of the next part of the foundation? A microphone that works would be key, yeah?
Look, in a sense, I actually think it's back to the future. I look at what Glenn has led. I look at what the partnership over the last 10 years has done. What they have done is implement a massive raft of strategies totally based on the evidence. Everything from early intervention through to prevention, through to management of chronic illness, through to community activation, you name it. The diabetes Western Sydney has been there and proved that it works and shown the evidence. What is changing now is the fact that finally policy frameworks at Commonwealth and state level are catching up. So they're starting to reflect the evidence. Things like the National Health Reform Agreement, like strengthening Medicare, like My Medicare, which will see people join with a local GP, will give the federal government the means to invest into general practice quality, equity, access, and outcomes. None of that has been in place before. So when you hear people like Ken Seng Lim talking about what he's doing in his practice, it's actually cost him money to do that. No one's paid him to do that. He has pioneered ways in which he not just manages the practice population in a proactive way that empowers his own practice population, but works with the PHN to actually build health and sustainability in Western Sydney. So I think that the groundwork's finally paying dividends in terms of national policy framework. We're finally seeing the Commonwealth and state come together and say to PHNs and LHDs, you need to get your act together in terms of joint governance. We'd like to know what your joint governance arrangements are and tell us by the end of this month, please. Well, you know, that is a brilliant outcome. So there's every chance that we can go on from here. The problem, and it is a major problem, is have they got the bravery to invest as fast and as deeply as needs to happen? You mentioned earlier on about general practice. Instead of having 40% of our medical graduates going into general practice, we're down to about 15% or less. That is that is a disastrous state of affairs, and primary healthcare in general is in much the same boat. So whilst the policy framework is ending up in the right direction, it is going to take far more in the way of dollars invested carefully to reward the right things, quality, equity, outcomes, and in a hurry if we're going to reverse what is otherwise going to massively undermine the whole system.
And Andrew, PHNs have a key role in facilitating this and enabling it. What enablers do you think should be promoted moving forward?
I think from a Western Sydney PHN and Went West perspective, it's going to be continuing with the research, the data analysis, but I think it's going to be lobbying and taking a joined up approach. And I just wanted to make some observations from the discussions tonight, and that's been, we've talked a lot about, heard a lot about the health budget topping $30 billion. It's not only health's responsibility. We really need to think about the other portfolios such as sports and transport coming on board with this. I got off the train coming here this evening and came up the stairs at Blacktown Station. The first thing I was greeted with was a McDonald's. Next door to that is a tobacconist selling all the rubbish that it sells. Then coming up Main Street past about 6 convenience stores selling lots of things. Now, I'm 9 months into my experience with type 2 diabetes, and I nearly came off the wagon on the way up tonight. And then get out in the door here, and there's the bus shelter, which the Lifestyle Group are really pushing the 2 kilogram challenge. That needs to be at the platform of the train station when people are getting off the train, not at the end of that trip. And it's thinking about how can the PHN advocate for those sorts of things across different levels of government. And just to pick up one of the points that Jasmine said, it's not just the ABF funding that is a state issue. It's what the state government in health think is important and what is not. And so these guys are under immense pressure for ambulance ramping, ED performance, surgical waiting lists. Jasmine doesn't get a call to say how many patients with diabetes have you treated today. So it's really thinking about
There's no waiting list for diabetes prevention.
Exactly. It's not publicly available. BHI could really think about looking at the measures that are really going to make a difference there. And because the PHN is outside of that loop, we could potentially use our role to advocate and lobby for changing those measures.
Thank you very much. Glenn, I'm going to depart from the planned programme. I think you should come up here and talk about your vision for where it comes from pulling it together. And I believe that there's a musical interlude to end as well. So thank you all to your panel. If you just stay there for the moment, and I will, Glenn, to close.
Just before I do the thanks, you might think about, we've been on this journey as Western Sydney Diabetes, our 10-year celebration. But what is Western Sydney Diabetes? We sent out an invitation. You all saw the list of people that have come tonight. And I'm really encouraged by that. It's an amazing list of high-level variety of people. You've seen the panels as they interact, not having enough time to talk, but getting out some very key messages. So what we do in Western Sydney depends on everyone here. You all are Western Sydney Diabetes. And if we could actually harness what we've had here tonight together, it could, the next period of time could be a game changer, an accelerator. You know, having federal, state, local governments working together, having public, private, civic groups working together. And Norman, you can't get off the hook here, having media get behind us so that the message can get out about what we're trying to do. I think the challenge really is for every one of us here tonight that you are Western Sydney Diabetes, and let's do something a little bit more extensively if we can harness what we've actually got here in the room. That's what I would like to see. I really want to thank Morgan and the Lifestyle Group for being the host tonight and for having us here and hosting so many things we have done. Thank you very much. I want to really thank the exhibitors. You really went out of your way. You came so early. You put up all the stuff. It was so enthusiastic to say some of the things we're all doing together. So that's a big thank you too. You know, it's pretty amazing to get one of these people on the panel that we've had on the panel, but to have so many people on the panel without enough time to talk, but at least you can see the variety of the energy and the contribution. The panellists have been fantastic. Thank you. And Jim and Norman, what great MCs. You did a fantastic job for us. Thank you so much. I do want to finish right at the end tonight with something that comes a bit from my heart, because it's about what we can do very simply together. And I kind of put the lyrics of the word of this song together, and I got someone to make it a song, but to also recognise that it's not just Glenn Mabley here that is doing this, it's all of our core staff. I want them all to come forward, and we might play the song, but all the core staff, I know that they're very reticent to do that, but please come up on the stage and then let's listen to our song in celebration. So this is our message, and we should all learn and sing this song together. Thank you.
Congratulations, Western Sydney Diabetes, on your 10-year celebration. Diabetes, it's bigger than we think. But there's a way, let's find the missing link. Even if you're feeling fine today, get your blood checked, don't delay. Drink more water, cut down all the sugar, eat healthier, let's make that much clearer. Move your body, get your heart in gear, take your medicine, push away the fear. A few kilograms, prevent the disease, make those lifestyle changes with ease. Eat better food, less processed, more greens. Together we can beat diabetes, it seems. Drink more water, cut down all the sugar, eat healthier, let's make that much clearer. Move your body, get your heart in gear, take your medicine, push away the fear. A bit of exercise, a little bit of care, small steps together, show how much we did. It doesn't take much to make a big change. Let's all take action. It's the time now for our lives to rearrange. Woo! Drink more water, cut down all the sugar, eat healthier, let's make that much clearer. Move your body, get your heart in gear, take your medicine, push away the fear. Drink more water, cut down all the sugar, eat healthier, let's make that much clearer. Move your body, get your heart in gear, take your medicine, push away the fear. Diabetes, we're coming for you. One small change in a life that's brand new. Everybody wins choose what we choose to make. A healthier path for everyone's sake.
We were going to hear from our MCs, but I think we're to the point at when we said at 8:30 we'd stop, so we will stop. And thank you so much, everyone, for coming and being part of it.